Okay, bone evaluation. This one in particular is an example of a site-specific ridge height problem. So you can designate this as ridge height. It's in the red, and it is also very much a red for bone density. So this is those two examples. The other things, nerve, IA nerve, facial bone, those aren't really our concerns at this point with this case. So patient comes in, has a problem with the lower left side. Looking in the panel view, you can see why he has a bridge that had too much force on a root canal treated tooth, fractured, but never got its surface to kind of let the bone eat itself away. What happens here is that the bone is getting eaten away because the body is trying to reject this piece of tooth that now looks like a splinter to the body. It looks very foreign. And so it can't do that because it's connected to this tooth, because it has a bridge. It's basically three connected crowns that hold this root in and causes this infection. So it's more of a rejection is really what it is. So let's look at this case here. What is it that we could do here? Well, he's interested in implants, and from a panoramic view, this looks valid. But the problem you have is that in a panoramic view, the bone height looks this high. And it's basically your two-dimensional picture smashing on a one-dimensional plane here, and you get duped by the idea that this is okay when it's really not when you look three-dimensionally. So that's why CT cone beam is so important, and to really look at the complexities of what people bring to us. Now, here we have a case where we have to do something restorative down the road, and if we go with implants, that means that this site here is no longer a bridge. It's no longer going to be a bridge from an implant, let's say, to a natural tooth. That's one of those dogmas that we don't like to do, where you don't bridge a natural tooth to a implant tooth. So take a look at one of my other videos about that one and why we don't like that. However, I do that from time to time just because it's a case-by-case situation. If we don't do that, implant to natural tooth, that means we have to have an implant in this edentulous site right here, in this site. So we have to evaluate this site for an implant, as well as the outcome or the predictable outcome that we're going to get bone back in this site when this gets taken out. So right off the bat, I would say with this large of an infected area, you're missing that much bone, it'll never be an immediate placement. There aren't implants bigger than the tooth, that's for sure. So you're looking at a two bone healing event, one for a graft and one for the implant. That means it's going to be a minimum of about 8 months before this patient sees a tooth. So let's evaluate this infected site, and let's evaluate this site here with our slice view. And let's bring that over, all the way over. Okay. First off, the infected site looks really bad, and we know there's already a fracture in that root. But the problem is now that I'm looking straight down the middle of where that tooth is, we only see a certain amount of bone. And that bone only goes from here to here. So you have to have the implant in bone. You have to. So if the best we could do in terms of grafting is from the height of the existing bone down into a socket site, the problem is now our height of bone has dropped tremendously. And to give you an illustration of that, we're going to put the implant back into this site and show you just about where that could end up. Now this is a fairly long implant, and I'm now approaching onto the nerve here. The length doesn't matter that much I believe that's an 11.5 millimeter length of an implant. But that doesn't really matter. Yes, it's a 4.2 by 11. That's appropriate for a traditional premolar size. But the problem I have here is where the height of this implant actually is. So let's go back to our panel view and see really where that ends up. And now you can see if the Panorex X-ray, if you only had a Panorex X-ray, it would kind of want to tell you before you start, well, we probably have this much bone, and you know, a worst case scenario, maybe your bone is really down here and your implant's here. Well, in reality, as this is going to heal, you're going to have a major, major defect. Now, I understand you do have bone on either sides of the walls, but that defect is so gigantic going straight down, and it's fairly wide. Let's look at this view. We're looking at it from this view, and I'm going all the way down to the base where the implant is. That's the top, that's the implant here. Look how big that hole is. And when I get to the top of the implant, I'm missing a ton of wall over here and here. I only have wall from here to here. Now remember I said that D1 and D4 bone are really not good bone for healing, that there's not a great healing capacity on either one of those. One, too little mineral, and it's not going to put more mineral just because you put an implant in. It's actually just going to stay the same. So we use compressive effects. I have talked to an oral surgeon. He says he's tried putting graft material into a D4 bone situation and try to create an osteoinduction effect and create some density with that mineral. He believes it actually works out pretty well. So you could always try that. I would only recommend that possibly maybe in the upper arch, maybe some arch areas on the bottom from time to time. But you really got to make sure you keep the sterility very high if you start doing something in that nature. Now here we have all this bone loss, and in this case you can see how dense the bone is here and here. So it already doesn't have a very good capacity to heal bone from the sides that have bone. So now your graft really has to hang out there a longer time to actually try to grow that bone across, because on the facial lingual sides there's no bone to grow at all to help grow that in, and all you have is tissue invaginating into the area, collapsing it. So you really got to make sure you try to protect that graft from movement to help that defect. So this case would be a really good case to look at it using a titanium mesh or some sort of hardened, reinforced PTFE type of graft membrane. But this could be one of those really cool cases where you get some of the specialty graft materials and membrane materials to try to rebuild that ridge back up to a height that you would have an appropriate implant. But that, I would say, is going to be a 5, 6, 7 month period just on the graft alone. And then here's one of our problems. If you put an implant in there, let's say we are at this height. Clearly the height problem is apparent because you have to still make your tooth all the way up there. So this is really a height issue where the prosthetic is just too high of a load for that implant. You have any lateral movement, you're going to crack the mount on something like this if this person's a real grinder. But the other thing is, so once you have that graft in there, and let's say you solve that problem, and your implant now can come up to kind of where you would want it, which is more where like you would predict if you only had a panoramic X-ray. But that really requires that you maintain quite a bit of bone. Over half the implant has to get into this new bone that you've kind of helped create with your specialty graft material. So this is not a trivial thing at all. I wouldn't do that. I'd probably refer this one to a periodontist that really understands grafts and structures and membranes to do this one. Now, the secondary problem, if we go to that edentulous site next door, remember I said the healing capacity is a little bit compromised because we have D1 bone on the opposite edentulous site that's currently there. And you can just see how dense that bone actually is. So we have a pretty good view here that that's not great bone to drill into, and it's very difficult to put the implants into very hard bone, and the implant doesn't want to heal in this bone. So right now I would give this guy a red for an implant system in this site for sure, and I would give him a red on the other site until I see the bone there. Then I reevaluate that site and make sure that we do have bone there. So this site, this whole case, if the treatment plan goes towards an implant, this is a non-starter for me. I would make sure I let that patient know that the time and effort to get an implant in here is going to be long and arduous, and then here you had to cross your fingers on the red here. Now, what could the patient do? Well, you know, you have to take this out for sure, and you should graft it. So for sure the patient needs an extraction and needs to do a graft. Even if it's just a particulate graft and you cross your fingers, nothing fancy dancy, you just gotta do the traditional socket graft material. That would be the case for that. Now, when, let's say you don't have an implant option, doesn't want to elect the implant option, then you would do a 4-unit bridge. This is a premolar, so you should have enough tooth structure to do a 4-unit bridge. That's pretty valid. If you want to up the strength of that, then you treatment plan a 5-unit bridge for this case. I don't do partial dentures, but you could also do a tooth-borne partial denture here, which then has a clasp here and a rest seat on both of those teeth. And that could work for some people that want a removable prosthetic. Or, I guess you could do nothing and you jeopardize the other side with too much force.